I'm back.
Hi, Senator.
And I will forego my 3-page opening comments.
I'd love to read them, though.
And we'll limit all my comments to panel 1. And I have a whole lot of questions, but then I will say to my colleagues, I will be very quiet after panel 1 is done. So I will begin. At the first hearing last spring, your Chief Deputy Director of Policy, Dr. Bonnie Sorensen, testified on behalf of the Department of Public Health. I understand she has since left the department, and I certainly wish her well. She did a great job. And I am concerned about the position in which her departure leaves the department. Given her important role in coordinating the state's efforts to manage this disease, and I want to say just up front, it looks like at varying levels of severity, 30 to 50% of Californians could get the swine flu. So that's the big thing that I want to put out there, because it's going to affect a lot of us and a lot of our loved ones. So it's imperative that this position be filled as soon as possible. I have probably 30, 40 questions, and we'll go from here. Can you tell us the administration's exact timeline for replacing Dr. Sorensen and whether qualified candidates have been identified? That's the first question.
We are certainly in an active recruitment phase. In the interim, we have chosen Dr. Chavez and Dr. Linda Rudolph, who is the director of our Center for Chronic Disease Prevention and Health Promotion, to co-share the responsibilities that Dr. Sorensen had, and we think that that is a very effective interim solution. We are very actively recruiting a replacement. We have a panel of interested individuals that we are evaluating at this time. We do not have a firm timeline for when we hope to have that position filled, but it's as soon as possible.
So given this is the end of August, and given there is great accountability when one really has replaced it with a permanent head of the department, or in this case, Deputy Director of Policy, are you hopeful that you'll have someone in the position by October, or how actively are you trying to get to that point?
Once again, I hesitate to commit myself or anybody else to a specific timeline. These positions are difficult to fill with qualified individuals, but we certainly recognize the importance of that replacement and the key role that that position plays in the overall management of the department, and specifically taking a lead in our preparedness efforts. So we're very aggressively approaching that. Thanks.
Thank you. And you know how well you and I get along, so I just have to get through all of this because I really care, and I have grandchildren. And so I don't want to see 30 to 50% of Californians getting the swine flu, nor do you. I urge the administration not to delay in finding a worthy candidate for this position, given the importance of this role in influencing the state's response to the pandemic and our need for strong, consistent leadership from the department. Next point. Next issue for me would be the availability of antivirals and the N95 respirators. At the first hearing, we heard testimony that not all of the local health departments were adequately prepared with pandemic flu plans, which concerned me. In response to testimony, I wrote a letter to Dr. Bonnie Sorensen requesting that the department follow up on my suggestion to scrutinize every county's pandemic flu plan, provide a stamp of approval for the plans, and submit written information to me relating to the status of each county's plans. Dr. Sorensen responded to my request very thoroughly by conducting a survey of the 61 local health departments to determine the status of their plans for distributing the antivirals and the N95 respirators. The responses showed a number of gaps in the county plans. For example, nearly 20% had not assessed their local healthcare providers' needs for antivirals. Over 25% did not have a plan for antiviral distribution, and almost 29% had not assessed their local providers' needs for respirators. Only 56, and 56 is not bad, but we're aiming for 61 out of 61 departments, responded to Dr. Sorensen in the time allotted, meaning you and we were missing information from 5 departments. Dr. Sorensen indicated that DPH would follow up with all local health departments, including the 5 that did not respond. So some questions for you would be, did that happen? including following up on the 5 that did not respond, and who are the 5? Would be my first question.
I feel confident that we have responded and done significant reviews of the locals' plans and given him technical assistance on how to improve those plans. With your indulgence, I'd like to invite Betsy Lyman to the table to respond specifically about whether those 5 had been responded to. Betsy Lyman is the chief of our Emergency Preparedness Office and overall coordinates our activities in the department in that area.
Well, thank you, Ms. Lyman. Yes. If you could respond to what has happened, particularly with the 5 that did not respond, and really who are they, and what are you doing to see that they do respond, and what are the results of that follow-up?
I didn't bring the name. I'm Betsy Lyman. Good morning to you all.
Good morning.
I did not bring the name of the 5, but we can get that and send that to you. But let me tell you what we have done.
Yes, we would like a copy of that, please.
Okay. We have a regular communication with all of the local health departments, specifically around the distribution, dispensing, the management of all pharmaceuticals, with particular emphasis right now on antivirals. So,
and then I will have very specific questions on antivirals. At this point, my main concern really is just in terms of the 5, who they are, and you're getting that information to us within a week, I'm sure. And then what are you doing with the results of that follow-up?
Yeah, well, what I was going to say is that we have been following up with all local health departments across the board through on-site visits. We have been to 19 local health departments since the time of the last hearing and have been discussing that with them. And we will continue to make those visits to all local health departments. We held a conference at the end of July here in Sacramento for all local health departments. We spent a full day on H1N1 preparedness in general, and in addition to that, we scheduled about half a day of sessions that were specifically around, again, stockpiling and distribution of pharmaceuticals with specific emphasis on antivirals.
So I'm just trying to be brief because I know at some point my colleagues will think, Elaine, you really need to be a little quiet on this. But so how are you utilizing this information? How are you gathering it and utilizing it?
We have a requirement.
And disseminating.
We have a requirement that each local health department use have a acceptable plan documented in writing for how they are handling, how they will handle pharmaceuticals. This is based on CDC's requirements for local health departments for the Strategic National Stockpile. And we do a on-site assessment and require each local health department to specifically go through item by item in this assessment, which is very comprehensive, and tell us exactly where they are and to show us the documentation that they have for their procedures.
Thank you. I'm now on item 2B, and I have 5 items altogether to ask. On 2B, my point is your letter claimed that many departments were in the process of finalizing their plans for the distribution of antivirals and N95 respirators. Given the disease's potential to spread, I think we should be well beyond the stage of being in the process of. As I mentioned, the results of the survey indicated that a quarter of departments surveyed still did not have sufficient plans for antiviral distribution as of last May. A couple questions on this point. What steps, well, you're telling me what steps that you are taking to develop sufficient plans.
Right.
And that you will get that information to us in writing. And can you confirm to us in writing that all local health departments have antiviral distribution plans that are complete and sensitive to local needs? Because we're really talking about the locals really bearing the brunt of this.
Right. And given the diversity of geography and population in California, each local health department does develop a plan that is appropriate for their jurisdiction. We require them to work with their providers and with their communities. We also required them to, over a number of years, to have plans in writing with us, as well as maintaining them locally. One of the questions we asked them was, all right, since you've had a plan for pharmaceuticals in general, on file with us for a number of years, and we know you keep one locally. Why did you say you didn't have one? And some of them said it really was related to at the time that they responded, that it was due to the uncertainty, this evolving virus. But we continue to work to get clarity on that.
Thank you. You told us last time that you were stockpiling enough antivirals to treat 25% of the population. First question, have you done that?
Yes. Between the antivirals that we have here in California, either in state warehouses or stored securely at the local level, and the quantities that the federal government stores for us, but that are earmarked specifically for California, we do have about 9 million treatment courses, which is about 25% of the state.
And have you sent that to us in writing?
I believe we have, but we will verify that.
Thank you very much. How much more do you think we'll need in coming months, and how do you plan to acquire additional supplies should they be needed?
Well, once again, we have under guidance from the federal government, we have developed a collaborative cache between what we have and the federal government to treat up to 25% of the population. So we have I think 3.7 million of those doses on site here in California, and we have another 5.3 million at the federal government in the strategic national stockpiles. One of the things I want to crow about is this spring, in anticipation of this, we were actually successful in receiving 1/4 of our total allowance of antivirals from the federal government to receive them, and we then in turn distributed those to 50 jurisdictions here in local jurisdictions here in California, and we managed to do that over a very short period of time, 3 to 4 days. So we think we've really exercised and demonstrated our ability to distribute those effectively.
I commend you on that. But as someone trained in mathematics, if I look at understanding that we have enough to treat about 25% of the population, and yet 30 to 50% of the population at a varying degree may very well get the swine flu, that there's a disparity there.
And, well, once again,
would you say to that?
The 25% is sort of like a cash to be used as a cash in last resort. We're fully expecting and are confident that the local healthcare providers, hospitals, and clinics and pharmacies are stocking up on antivirals, and that will be the first line. So it's hard to quantify how much of that is available out there in the community.
And you're asking for them to put this in writing to you, what they are able to stockpile and use.
Betsy, can you ask what specificity we're getting?
Yes, what specificity are you asking of the locals in order to prepare for the swine flu pandemic?
We have told them that of this cash, federal state cash, that will be available for use as a last resort, we've told them what share they will get of that, so they know the numbers, and we have asked them to tell us what their plans are for how they will make that available to those in their community who are in need of this, who can't get it through a private source, who clearly are at level of illness that is recommended that the antivirals be used.
And where I'm going with this question is, you are assuring us that you can provide about 25%. And you are also saying that the locals are responsible in coming up with a certain percentage. And how we need to be reassured in writing is that what you have plus what they have is going to be 100% of what we need. And are you able to assure us of that? Because we really are responsible at the state level, and the public believes that we are taking care of this.
Well, as Dr. Horton indicated, the antivirals are provided through the private sector, through the regular delivery of health care, and many individuals receive them that way. This cash is intended for a last resort, and it is available to be distributed to those who need it.
And what I'm suggesting is that we are really responsible at the state level for understanding how much is really available to protect the public. I mean, you can say that it's really private sources, But I would suggest that we need to understand and work in a public-private partnership to figure out what the privates can come up with, so that what we have plus what they have is going to be enough. Someone has to be responsible for saying, yes, we have enough in the state of California. And I personally believe DPH ought to be out there saying that. So if you can't say it today, we'll have another hearing. And I know this is really hard work, and we're breaking new ground, et cetera. But I really want us to be able to say that to the public, because we are accountable to them.
Appreciate that, and I think that's a reasonable question to ask. What is our best information about the total resource available to us? Certainly, in addition to the cash that Betsy and I have both mentioned, we do know that some local jurisdictions have spent some of their preparedness monies on antiviral medications and have stockpiled those. We certainly can quantify the amount. It's very difficult to quantify what's available through the private sector, but we can certainly make efforts. In addition, it's not like that 25 is forever fixed. We fully expect that the federal government, as we draw down resources from the federal government, they are already working with manufacturers at the federal level to begin to replenish those supplies and hopefully could make those available to us. But I respond to your request for further specification and clarification of what the resource is available to us.
I appreciate it. And speaking about the resources, I'm on 2D now. I'm hearing reports that the virus could become resistant to Tamiflu. Have you taken this into account in your planning? And are we stockpiling additional types of antivirals? And where might we be in that process?
First of all, the message so far is very positive. There are literally been no more than a handful of cases throughout the world that have of H1, the novel H1N1 virus being resistant to Tamiflu or oseltamivir, the most commonly provided. So on the one hand, so far, the news is good that and this has continued through our experience.
And you're monitoring that.
I'm sorry?
And you are monitoring that.
Absolutely.
Absolutely.
As you mentioned before you came in, Senator, one of the things we're doing here with our laboratory capacity here in California is we are constantly monitoring a subset of influenza specimens, specifically to monitor whether the viruses grown are sensitive to oseltamivir, Relenza, and the other antivirals. And the second part of your question is we have hedged our bet a bit in the sense that we haven't just purchased Tamiflu. We have a certain cache of Relenza, which is another antiviral medication. So we have some preparations to deal with the fact that some or all of the virus may become resistant.
I appreciate you thinking outside the box on that. Next question. According to the survey, 46% of departments still did not have a plan for distributing N95 respirators to healthcare providers as of May. That was May. Only 71% of local departments had even conducted an assessment of their providers' needs for respirators. So my questions on this point are, what has DPH done to follow up with local health departments on their respirator distribution plans? And can you confirm to us in writing now that every county has a sufficient plan when it comes to the respirators?
I'll ask Ms. Lyman to respond.
On N95 respirators, the department has been looking at the guidance that we have provided as to when healthcare workers should use them, and I know that Dr. Horton and Dr. Chavez can speak to that. In addition, we have been working with an advisory group of local health departments to talk specifically about the triggers for when we release state allocations, specifically the guidance that we provide, and we are doing this in consultation with providers and with Cal OSHA, which implemented a new respiratory aerosol transmission disease standard at the beginning of August. So we have been working quite intensively on this, and so we have not yet issued the formal guidance. We have instead been working on drafting it, and what the issues are that the local health departments need to have covered in there, and we will issue it.
Thank you. And so continuing on that point, many local departments expressed concerns in the survey that there were shortages of these N95 respirators. And obviously the whole purpose of the respirators is to protect healthcare workers from contracting the virus from infected patients. Yet we've heard reports of healthcare workers falling ill from the disease and dying. So what is the status of the N95 respirator supplies now? And do we have a sufficient amount to meet our needs through the entire flu season? And can you put that in writing to us, please?
Go ahead.
Go ahead, Betsy.
The state cash that was purchased in 2007 was predicated on the assumption of hospital healthcare workers using an average of 3 N95 respirators per day for a period of 6 months from the onset of the virus until the vaccine became available. Clearly, that was predicated around assumptions for an H1N1 virus that was full-blown before it reached California. So despite the fact that we have what appear to be a large quantity, it will not go far when used as indicated. We have, but as with the antivirals, this cash was intended as to be used as a fail-safe backfill for what is for hospitals and other facilities obtaining their respirators through the private market. This has been a challenging area. And so there are a variety of issues, and of course, the issue of fit testing in a respirator is one that's important for a hospital in trying to continue to use the model that its staff have been fit tested to. However, that the manufacturers are indicating that while they're telling us that while their supplies of what they are manufacturing has increased, so has the demand from the private sector to purchase them. So there are some respirators that are available, but not necessarily the ones that a particular healthcare facility may have its staff fit tested to. There are possibilities of using industrial rather than healthcare protection N95 respirators. The Cal OSHA has been looking at the issue of how frequently and when a respirator can be reused. As I indicated before, we have looked at the case definition of when an N95 should be used. So there are a variety of different approaches that are going on, and we will continue to work on this issue.
Thank you. And on that point, I have some comments. One, I realize it's a difficult area. And we've talked in the last hearing about how we work with hospitals in terms of what they are doing and what we should be really saying. And I really believe, as I said earlier, that the public believes that they are going to be safe. And whatever we need to do with private providers or public hospitals or what have you, we need to be aggressive in doing that. And I'd like to talk a bit about on the fit respirators. The first, and a question is regarding the sizes of the respirators. According to guidance from the CDC, N95 respirators are supposed to fit closely to form a tight seal over the mouth and nose. Be fit tested and adjusted to one's face, and to be safely removed and discarded after use. We've heard recurring reports that these guidelines are not being followed. We've heard that healthcare facilities are requiring to reuse respirators in spite of recommendations that the respirators not be reused. We've also heard that facilities do not have the correct sizes of respirators. So here are the questions. What specific steps have you taken to ensure adequate supplies of all sizes of respirators and availability? And when DPH estimated the quantity of respirators needed, did that estimate account for respirators being disposed or being reused?
Let me start with the last one. When we acquired the state cash in 2007, we went to hospitals and asked them what particular models that they were using, including sizes, and we ordered around that survey that was done at the time. That may not necessarily match what the hospitals are using today. So, in fact, as respirators continue to evolve, the changes occur in what hospitals are actually practicing. So we do have different sizes of N95s. We recognize, however, that may not meet the current needs of all of the healthcare facilities that may be using them.
I'm going to request that DPH require that all hospitals account for what they have in terms of supplies, including these respirators, and what they need to do to fully protect their healthcare workers, because we are going to be dependent on those healthcare workers when people become ill with the swine flu. So if you could provide that to this committee, that would be great. We've heard complaints about inadequate protections for healthcare workers, like there aren't enough masks, that masks are being reused, or that patients with viruses are not being properly isolated. How many complaints have you received, and how are you, tell us about how you're investigating them, how many citations have been issued in all these different categories?
Yes, as of the time of this hearing, we are not aware of any complaints that have specifically been filed with our department. And if you have different information, we would certainly like to know about that.
Yes, we do have different information.
Right.
We'd be happy to share that with you.
Great, good.
Okay. Next, in the first hearing, we heard complaints from the clinics about lack of personal protective equipment and lack of communication from the state. I think you remember some people testified on that. I've since heard from clinics that in spite of the progress that was made at our first hearing in April, and I appreciate your receptivity to this, that there are still concerns about personal protective equipment, PPE. And I wondered, have you surveyed the supply of PPE, and what is the backup plan if there is a shortage of personal protective equipment?
Well, again, we have continued to encourage that it is a responsibility of a healthcare facility to make sure that the basic supplies are provided through their normal operating procedures for obtaining them and using them. Aside from N95 respirators, the PPE, the state does not have a cache of PPE. At the beginning of this hearing, Dr. Horton spoke to the funds over a number of years that have been provided to the local level through the hospital preparedness program. And it is a requirement that of ours that clinics, long-term care facilities, and hospitals, along with other partners, participate in the local plan each year for how those funds are to be used. A lot of those monies have gone to facilities specifically to augment the supply of PPE, personal protective equipment, that they have provided through their normal operating business.
Okay. For those in the public who might be watching this on TV at some later date, PPE, personal protective equipment, are things like gloves, masks, gowns, and any other clothing or equipment designed to protect a person from infectious materials. So I would request of DPH that you communicate with hospitals and ask them, if 30 to 50% of people are going to have swine flu at some varying level, what is the hospital? I mean, the hospital should have a plan for having these basic pieces of equipment, gloves, masks, and supplies. And that has to be beyond what they would have in the normal course of the year for other things that they need. And so I would...
Absolutely. I think that a key component of dealing with an anticipated surge capacity needs in the healthcare facilities is protecting the healthcare workers and instituting effective infection control procedures in hospitals.
And you said it better than I did. Right. Now, if you can ask the hospitals to provide
we have begun those
a plan for that.
conversations and have made it very clear what we think are priority efforts that need to happen in all healthcare facilities, both to decrease the likelihood of them themselves becoming a spreader of infection by rigorous compliance with infection control procedures in the hospital, and then secondly, as you've mentioned a number of times, takes significant steps to ensure that healthcare workers are protected by making sure they have access to personal protective equipment, including the N95s. And I would also mention making sure that they have already been selected as a priority group or a target group for a vaccine as it flows. We got to make sure that healthcare workers get vaccinated to protect themselves and make it less likely. We've not got a good track record of that in the healthcare community in the past, and we're working to help communicate and emphasize the importance of them stepping forward and taking those steps.
Thank you. So, Dr. Horton, what do you think is a reasonable time frame to be asking hospitals to provide information to DPH in terms of these personal supplies? What's a reasonable request, reasonable timeline?
Well, we certainly have, once again, begun those conversations, and we think that that kind of information should be forthcoming from them in a fairly timely way. So we should in the coming weeks, we think we ought to be able to accumulate more of that information.
Great. So I would be hopeful, certainly by October 1st, that the hospitals would be able to communicate to you what supplies that they have in terms of PPE, and if they do not have enough, that they have a plan that they are presenting to you that you can share with us as to how they are going to accumulate them. Thank you. Next, I'm on question 4 now. We're almost through. Federal officials recently scaled back the number of flu vaccine doses they expect in October from 120 million down to 45 million. How many doses of the vaccine do we need to vaccinate our priority populations here in California? How many doses do we anticipate receiving? What do we do about the shortfall? And what specific guidance is DPH issuing to ensure that priority populations are vaccinated first? That this particularly important, and that this is particularly important given the shortage of the vaccine. We're not going to have enough vaccine for all the people who need it. So how are we going to deal with this? And whomever wants to answer this.
Just to make a few initial comments and then pass it on to Dr. Chavez for some of the specifics, that our understanding is that this is not, well, while they have scaled back the number of the first allotment of vaccine, they have not changed their goal in terms of the total number of vaccine that they produce. We're hearing that they are expecting to produce 200 million doses of vaccine, and instead of 100, they will be more like 45, but they will continue to deliver probably in weekly allotments, 20 million doses per week for the next 7 to 8 weeks until that entire stockpile has gotten.
And they've communicated that to you in writing? So that you know it's coming?
I believe we've seen that in writing. I have been participating in numerous calls in which that information is regularly updated, and my information is that we have that in writing. I'm going to kick it to Dr. Chavez, though, to talk about how much of that is coming to California.
Yeah, thank you.
And priority groups.
You know, this actually changes weekly. We are in constant communication with the federal government, and they give us estimates every week on what we can expect. As of the 19th of August, we were told that we could expect by the end of September, early October, the first shipment of 2 million doses of vaccine to California. And then from there on, we would be getting about 2 million doses every week.
Great.
To cover our population.
Well, that's good news.
I think an important point that you raised is that, of course, we need to be mindful that that's not going to be nearly enough in the early stages, and that we need to make sure that those go to the target populations where we feel the vaccine will be most effective. And so we are actually setting up an infrastructure in terms of setting up a vaccine program where vaccinators, providers at the local level that actually serve those target populations will get the vaccine first, so that they're able to distribute.
And Dr. Chavez, would you like to mention for the public who might eventually be watching this on TV, what are the target populations, the priority groups that should get the vaccine?
Yeah. So we have largely people under 60 years of age. We have children, pregnant women, healthcare workers, and individuals with chronic health problems.
Thank you. My next comment. We know that people with health insurance should be able to go to their doctor's office to receive a vaccine. but there are other locations that we generally allow to administer vaccines to the public as well, such as workplaces, pharmacies. With this disease's deathly potential to spread rapidly throughout the population, we must have the capacity to vaccinate as many people as we can with the doses we have at our disposal. Question: what additional types of vaccine administration sites will people have access to this fall? And what criteria will a location have to meet in order to be used as a vaccine administration site? Next question. Is DPH working with these sites to assure that data regarding the vaccinated patients is accurately tracked and reported back to CDC? And of course, that's particularly important because high-priority people need to get more than one vaccine.
Let me just begin with some comments and then again have Dr. Chavez complement. It has been decided that the distribution of the vaccine will occur pretty much through the same mechanism that has been used in the past to distribute a seasonal seasonal flu vaccine, which is a complement. It's complementary. A large number, in fact, the vast majority of the vaccine will go through private providers. These are pharmacists, physicians, clinics, hospitals, etc., that will be delivered through that mechanism. There will be others, community-based providers, community clinics, non-governmental organizations that set up clinics, and then, of course, some will come to the local health departments to set up free clinics in their communities. That same network, we're anticipating that there may be as many as 10,000 sites where vaccine will be delivered right here in California to ensure that there's broad access to the vaccine.
And Dr. Horton, I assume that DPH is on top of all of that in terms of all the different entities that you mentioned that would be receiving the vaccines. We're
working very closely with local jurisdictions. We will be the local health officers in the local jurisdictions that will get to determine the short list, or in some cases the fairly long list of specific individuals who will be approved to receive the vaccine, and it will be them that we're relying on and working with to ensure that that network of vaccinators is serving the priority populations that have been identified. So we feel like we're very much on top of this and working very closely with local jurisdictions to implement that plan.
I believe that. And if you could get that to us in writing, that would be very helpful. We would really appreciate that. Sure. I do remember from the earlier hearing that the community clinics were saying that they didn't seem to be involved as much, and I know that they're testifying today, but that certainly is one sensitivity to be sure that, you know,
they're a very key partner in our community.
That we're being very inclusive.
To.
Okay. What are the current federal and state plans and timelines for distribution of H1N1 vaccine to these locations? Do you have that now, or can you
once again, as Dr. Chavez mentioned, are the latest indications, and this has sometimes changed from day to day, but the latest indications that we may be getting our first allotment of vaccine as early as the end of September, certainly by the middle of October, that we're expecting that. And once again, we're anticipating that to come in a fairly large allotment initially, and that there will be subsequent allotments delivered to us on approximately a weekly basis until the full allotment has been distributed to California.
Thank you. And if a school in my district in Santa Clara County wanted to set up a vaccine clinic for students, how would they go about doing that?
They would approach the local health officer. Once again, it's the local health officer that will be able to determine which vaccine sites will be available to receive the vaccine, and that they're working with the local schools and will be in the best position to choose which of those vaccinators should be approved for reception of the vaccine to ensure that the priority groups or the target groups receive the vaccine first.
You mentioned something earlier about the number of people who would be priority. And I think what we need to keep in mind is that the number itself may not be huge, but it sounds like they need to get 2 or 3 vaccines. So we're actually talking about 2 or 3 times the number of people.
I'm glad you brought that up.
So let's talk about that.
This is very challenging. The fact of the matter is, what we haven't referred to is the fact that this mass vaccination program is on top of the normal seasonal flu vaccine.
People need to understand that.
Yes, that's very, very important. So that, for example, an individual like myself who wants to be totally and completely covered for what might come by way of influenza, I would get one seasonal flu vaccine, and I wouldn't be required to receive two novel H1N1 vaccines, and I may not be able to get all three of those at the same time, or certainly at the same, we can't get them at the same time, or even at the same place. There may be, so this is going to be a very, very challenging
It's going to be a
for us.
logistical challenge.
It is. We're very respectful of the challenges that lay ahead for the local jurisdictions, and we're doing everything we can
And so
to...
how are you helping the locals on that? I mean, I do understand that's more of a local issue, but what do you view to be DPH's role in that?
One of the things we're doing and finalizing, we are developing a template or a guidance document on how to conduct a local mass vaccination program. We've already submitted a draft of that and gotten comments from the locals, and we're hoping to finalize that plan literally within I won't make a commit. I'll let
a few days.
Well, a few days. Thank you. I didn't want to overcommit us, but the point is, and the locals are very much urging us to get that further direction as to what are the specifics on how you operate this plan. So we think we're going to be stepping forward very soon in providing the leadership and the direction on how to do that, and giving them the cookbook on how to put that together.
Well, that would be great. And you may know I'm a yaya, which is a Greek grandmother, and I'm going to be particularly looking at those 5 local departments that didn't do the work previously, and I want to be sure that all 61 are really creating these plans, because the public is dependent on all of us, Okay. Another emerging concern I've been made aware of is the type of vials being used to distribute the vaccine. It might be multi-dose vials instead of single-dose vials, in order to roll out as much vaccine to as many people as possible. Groups in other countries, and I will say other countries, have expressed serious concerns over the use of multi-dose vials, claiming that there have been examples of spreading infection between patients with HIV, hepatitis B, hepatitis C, and so on, because the same vial has gone into to give multiple, and it could be, and the disease could be spread that way, actually. Some questions. What can you tell us about safety measures being implemented here in California to ensure that diseases are not transferred via these multi-dose vials? I think we'll take these one at a time. So that's the first question.
I'm going to kick this to our infectious disease specialist.
Yeah, I think it's an important question. And, we in California do vaccinations all the time. We have a very good track record of doing massive immunization campaigns throughout the state. The issue of safety is its foremost importance for us. And in selecting who vaccinators will be, one of the criteria is that they will have to have adequate training on how to administer these vaccines. So we not just will allow anyone to vaccinate unless they can prove that they are qualified to do so. So part of our effort is in identifying vaccinators and then making sure that they have the right training to administer the vaccine. Clearly, adequate number of supplies to administer the vaccines is also going to be very important. So as part of our effort in administering vaccine, of course, we will make an ample number of supplies available as well.
And Dr. Chavez, how will the department track whether infections are occurring in the population as a result of multi-dose vials?
We're actually setting up a system for tracking each individual that gets a vaccine and then following up with them for 2 reasons. Number one, there's obviously concern of any adverse effects from the vaccine itself, and then also long-term effects. So since this is a novel vaccine and one that we really want to watch very closely, we're actually going to be setting up a tracking system so that we monitor individuals that get vaccinated over time to see if, hopefully, they don't develop any infection or any adverse effects.
And speaking of tracking, and I say this as one who chaired the Information Technology Committee back in the Assembly, I'm assuming that you're on the same kind of system and use the same kind of software with the locals in terms of being able to instantaneously track all of what will occur? Would that be an accurate assumption on my part, or how do you do that?
Not exactly accurate assumption. I think technology, as you said, is rapidly evolving, and I wish I could say that every single local health department and we in the state all have the same tools and the same software and the same programs for everything. That is a goal, and we're actually developing registries to do tracking of infectious diseases that will allow us to do that, to have a seamless exchange of information. But at the present time, that's work in progress.
So what I would request of DPH is if you can put in writing to us, please, how is it that you communicate with the locals in terms, and with hospitals and publics and privates, and how do you communicate in a very timely fashion what is going to be occurring with the swine flu and how we are going to deal with it? I'm asking, just basic, simple things like, are you going to be emailing? Or, really basic level, how do you do things quickly when all heck breaks loose? Because it will.
Well, one step we've put into place, of course, and has been one of the things we put in place with the resources that we've had available to us from the federal government is this California Health Alert Network. All the local health jurisdictions are hooked into that. In addition, we have thousands of other providers and entities at the local level that are hooked into the system so that we can instantaneously send messages, and we do on a regular basis, and during the outbreak sent multiple of these alerts on a very timely basis. So we have a very effective mechanism of getting messages out to local jurisdictions, and that works both ways. There are a subset of those who can actually not just read alerts, but can actually put alerts into it. So some of the local jurisdictions have the authority to actually themselves get an alert back to us through using that same system. So we have a fairly, that's one. Of course, we will put out, Dr. Chavez's shop puts out regular communicable disease reports and briefs. We put out health alerts in addition to those through other media. So we have numerous mechanisms, and we have, of course, these regular phone calls that have occurred on a daily basis. So we feel like we've got a very robust alerting system and communication system to ensure that we're communicating effectively with the locals.
Well, that's great. And if you could put that in writing to us in
happy
terms
to
of,
summarize that
because
for
the
you.
goal would be that you're actually covering 100% of those who need to be in communication with on that. Okay, I'm almost through. Actually, this is the last question. Okay, funding. Earlier this year, Congress appropriated funds for pandemic flu preparedness, and we know the federal government has already released its first pot of funds to the states. In light of budget cuts and the state of the economy now, local health jurisdictions are desperate for the second and potentially third pots of federal funds to be released. So two questions. They could be my last two questions. I just won't promise that. First, what is the administration doing to pressure the feds to release the remaining funds? And number two, what can we do here in the legislature to help? And of course, you know that all of the questions I have asked have been because I envision in this whole Capitol our community of family, of neighbors, of friends who all want to be safe during this horrible outbreak. And I only ask these questions and ask respectfully for responses to be put in writing because you have the ability, great ability, not 100%, but great ability to make this safe for us when it does break out. And we appreciate what you do. So just those are probably the last two questions.
Let me address the urging of the federal government. We've had a number of opportunities through a number of vehicles to communicate clearly to the federal government what our concerns are, what our needs are, and get them to respond. I am on the executive committee of ASTHO, the Association of State and Territorial Health Officers. This is an organization that's been very effective in communicating at all levels of government, through the CDC up through the Health and Human Services, what our needs are. And they have, in fact, been partially instrumental in ensuring that supplemental funds were set aside. And I think we're helpful in ensuring that we have early indications of our allotments, and we have at least early indications that there may, as you've mentioned, additional resources made available to us. Similarly, I had an opportunity to testify before a congressional committee, giving our state's perspective on our needs, and pointed out the stretching of our resources and the need for continuing commitment for the federal government to support our cause. So I think we've got effective communications. I've individually been involved in those, and through the Association of State and Territorial Health Officers.
Thank you. Okay, well, I would like to thank all three of you, Ms. Lyman and Dr. Horton and Dr. Chavez. I really appreciate it. Appreciate what you do.
This opportunity to update